Hello everyone. Hello everyone. So welcome to this ophthalmology INICET PYQ session. So in this session, what we will be doing is we will be doing the important questions that have come in ophthalmology in the INICET exam over the past few years. And I will try to discuss the important, not just the questions, but also other important, how to rule out the other options and also other important aspects of that particular question and that particular topic. Okay, so let us start with this. So let me start with the first question that we have. So the first question is, what is the action of the SO, that is the superior oblique muscle? And we have been given these different options: intorsion, abduction, depression, intorsion, adduction, elevation, extorsion, abduction, depression, extorsion, adduction, and elevation. Now see, this functions of the extraocular muscles is one topic that we really have to know very well. So what I'll do is, before we come to the answer to this question, let us just quickly revise the functions, the different eye movements and the functions of the muscle. So see, there are two ways in which this particular question can be asked. So let me just go through the topic once very quickly and then I will come back to the answer. So we have to remember that eye movements, they take place in three axes. So what are the three axes? First is if we have a vertical axis. So if we have a vertical axis, then the vertical axis means this is the fulcrum, or this is the center along which the movements are taking place. So if we keep this as the center, the two movements that are possible are adduction, that is when you move the eye inwards. So if I keep the vertical axis, I can either move the eye inwards or I can move it outwards. Adduction and abduction. Adduction and abduction. So which are my adductors? My main adductor obviously is the medial rectus muscle. The main adductor is the MR, or the medial rectus muscle, and it is assisted in this process of adduction by the superior and the inferior rectus muscles. So medial rectus is the main adductor and it is helped by superior and inferior rectus. Now, which are the abductors? The abductor is the lateral rectus and here it is assisted minimally by the superior and the inferior oblique. So this is if we keep the vertical axis as our fulcrum or our center. Now suppose we keep the horizontal axis. The next is we keep the horizontal axis as our fulcrum or the center. Now if we keep this horizontal axis as the center, then the two movements possible on either side are, I can either move the eye up or down, right? So if I move the eye up, that is obviously called as elevation. And if I move the eye down, that is called as depression. So elevation and depression. So now which are our elevators? Will any one of you be able to tell me which are the elevators? The elevators of the eye are obviously the superior rectus and the inferior oblique. And the depressors of the eye are the inferior rectus and the superior oblique muscle. So this is the second, that is the vertical axis we have done. Now with the horizontal axis. The third is if we keep an antero-posterior axis. Now suppose I keep an antero-posterior axis. Antero-posterior axis means this. So keeping this as the center, the two movements possible are, you can rotate the eye inwards or outwards, right? So if I rotate the eye inwards, that is called as intorsion. And if I rotate the eye outwards, it is called as extorsion. Now, which are the intorters and which are the extorters? Now, this is remembered by the simple mnemonic SIN. SIN stands for superiors are intorters. SIN stands for superiors are intorters. So, which are our intorters? Our intorters are SO, that is the superior oblique, and SR. So SO and SR, these are our intorters, and obviously therefore the IO and IR are our extorters. right? So these are the three axes on which the different ocular movements are taking place: the vertical axis, the horizontal axis, and the anteroposterior. Right. Now see, if we are asked what are the functions of the superior oblique muscle, which is the question. So where all can we see the superior oblique? See, the superior oblique, it is an intortor, it is a depressor, and it is an abductor. So these are the functions, of which the most important, which means the primary function of the SO, is intorsion. The secondary function is depression, and the tertiary function is abduction. Okay, so if I go back to the question, see what was our question? Our question was, what is the action of the SO, that is the superior oblique? So see which are the functions. So it is intorsion, abduction, and depression, of which the primary function, that is the most important function, is intorsion. So our oblique muscles are actually rotatory muscles or torsional muscles. So primary function is intorsion. What is the secondary function? That is the next important function. The next important function is depression. And the minimal action is, or the tertiary function is, abduction. So primary is intorsion, secondary is depression, and tertiary is. So these are the functions of our SO, that is the superior oblique. Right? So I hope this is clear to everybody. So see, this is how, if we remember this chart, then it becomes very, very easy to answer any question on extraocular. So this is like something which we have to know very, very, very well. Okay, shall we move on to the next question? The next question is this. A 27-year-old female patient presents with a sudden onset decrease in vision, and this is associated with RAPD, that is relative afferent pupillary defect. So there is a decrease in vision in the right eye, and there is RAPD, or relative afferent pupillary defect, in the right. And on examination, the left eye is normal. Now see here, the question is not really very complete, but it's a recall question. So they are probably pointing to the diagnosis of an optic neuritis. But what are the other features they should have told us? They should have probably told us that there is a decrease in vision which is accompanied by pain on ocular movements. These are other things which are usually mentioned in the question. So sudden onset decrease in vision, pain on ocular movement. On examination, apart from RAPD, which suggests an involvement of the optic nerve, now because there is RAPD, we know it's an involvement of the optic nerve, they should have mentioned that there is a red-green color deficiency. There is a red-green color deficiency. And they should have mentioned that the fundus is normal. The fundus is normal. If these things are mentioned in the question would be far more complete. So a female patient presents with sudden onset decrease in vision. Ideally, the question should say that there is pain on ocular movements, there is red-green color deficiency on examination, and there is RAPD, and this suggests the involvement of the optic nerve. But when you look at the fundus is normal. So all this gives us a diagnosis of optic neuritis. Now, which variety of optic neuritis? It is retrobulbar neuritis. Retrobulbar neuritis. Now, when you get this RBN, then one of the very, very important causes that we have to remember about optic neuritis or retrobulbar neuritis is what it is: demyelinating disorders. So, demyelinating disorder. So, if you have to, once you have confirmed the diagnosis of optic neuritis, then we have to keep the possibility of demyelinating disorders in mind. So, for demyelinating disorders, the two important demyelinating disorders that we have to consider are multiple sclerosis and neuromyelitis optica. Right? So, what are the investigations that you will do? See, the investigations that need to be done are these. You will need to do an MRI of brain and the orbit to look for demyelinating lesions. You have to obviously look at the optic nerve, so you need an MRI of the orbit, and you also have to look at the CNS for demyelinating lesions. And this, that is myelin oligodendrocyte glycoprotein and neuromyelitis optica antigen. Okay, so together this will help us to rule out demyelinating disorder. So basically the question is giving us a clinical picture of optic neuritis, though from this question it's not really clear except for the fact that they have mentioned RAPD, but these are the other things, as I told you, which are usually given in the question, that decrease in vision, pain on eye movements, RAPD, color desaturation or red-green deficiency, normal fundus. All this, sometimes they also give us that there is a VEP was done, visual evoked potential was done, and this shows that there is, which wave is affected, it is the P100 wave which is, or sometimes they say that the perimetry was done and the perimetry shows us a central or a centrocecal scotoma, a central scotoma or a centrocecal scotoma. All these may be mentioned in the question to make it easier for us to understand that they are pointing to a diagnosis of optic neuritis. Then the answer becomes much easier. So if it is optic neuritis, we have to consider or keep in mind the possibility of demyelinating disorders, and hence 1 and 2, these are the investigations. So therefore this is our answer. Right? Shall we go to the next question? The next question is this. Identify the condition that's given in this image. So let's have a look at this image. What do we see in the image? We see that there is a fusion between the two lids, right? So see, there is a fusional band which is connecting the upper lid and the lower lid. This is called as ankyloblepharon. So what is ankyloblepharon? Ankyloblepharon means that there is a fusion of the lids. It may be partial, as in this case, or it may even be complete also. So this is ankyloblepharon. I'll just take the opportunity of this question to show you a couple of other images. So have a look at this. Look at this image. What is this? The first one. This one is a symblepharon. This is a symblepharon. So what is symblepharon? Symblepharon is usually the result of some sequelae like some alkaline injury or acid injury to the eye, where there is an adhesion between the bulbar and the palpebral conjunctiva, or sometimes between the palpebral conjunctiva and even the cornea, as you can see in this picture. So in this picture, a part of the palpebral conjunctiva, see, there is a band which is connecting the palpebral conjunctiva to the bulbar conjunctiva and also to a part of the cornea. This is a symblepharon. And this is a picture of blepharophimosis. So in blepharophimosis, you will see that there is a shortening of the palpebral aperture. So there is a shortening of the palpebral aperture. You see that the palpebral aperture appears small to you, and also sometimes you have these epicanthic fold that also you can see in this picture. So there is a shortening of the palpebral aperture and there may also be epicanthic folds. So this is blepharophimosis. Right? So the picture that's given to us in the question, this is ankyloblepharon. Right? Again, a complete image based. Shall we go to the next question? The next question, which of the following is not a feature of pterygium? Which of the following is not a feature of pterygium? So what exactly is a pterygium? A pterygium is actually an elastotic degeneration of the conjunctiva. So it's a conjunctival degeneration, an elastotic degeneration of the conjunctiva, where a fold of conjunctiva grows onto the surface of the cornea. So it's a type of a fibrovascular growth. So if I just draw a picture, this is what a pterygium will look like. So see, this is a pterygium like this, and this grows onto the surface of the cornea. This is a pterygium. It's a fibrovascular tissue and it has three parts. This is the head, this part is the neck, and the rest of it is your body. So the portion that is on top of the cornea, that's your head. This is the neck of the pterygium, and then we have the body of the pterygium. It has progressive and regressive types. That's correct. Progressive means it is very, very flushed with blood vessels. It tends to grow on, it tends to progress. Regressive means that there are not many blood vessels. It is kind of atrophic. So regressive or atrophic pterygium. These are the types of pterygium. So all this is right. So it's a fibrovascular growth. Parts are head, neck and body. Progressive and atrophic or regressive types. These are correct. What is wrong is this. That is the rate of recurrence is 95%. Now, recurrence is the most common complication of excision of pterygium. So, the treatment of pterygium is excision of pterygium, and recurrence is the most common complication. But the rate of recurrence is for the bare sclera technique. That is for the bare sclera technique. That is where you just pick up the pterygium and you just pick up the pterygium and you cut it and you leave the sclera bare, which is the bare sclera technique, the rate of recurrence is around 80%. It's around 80%. So it's not 95%, but still it's very, very high. So what are the different methods that we use to prevent the excision of pterygium? The most commonly used method, or the preferred method, is the conjunctival autograft, that is CAG, conjunctival autograft. Or the drug that can be used is mitomycin C. Mitomycin C application to the bed of the tissue. And in case of very large pterygium where it may not be possible to do a conjunctival autograft, what you can do is you can do an amniotic membrane. So conjunctival autograft usually or most preferred method, and for very large pterygium where it may not be possible to do a conjunctival autograft, we can do an AMG, that is amniotic membrane graft. Okay, so this is the question on pterygium, which is a type of elastotic degeneration of the conjunctiva. Right? Shall we go to the next question? Next question, again simple question. Which of the following is not a feature of keratoconus? So keratoconus, what is this? This is a type of corneal ectasia, right? So in this corneal ectasia, what do we have? In this, there is a protrusion of the cornea which is associated with thinning. So a portion, it's not that the whole cornea is protruded, it's a localized protrusion. So if I draw a picture, it will be like this. So there is a localized protrusion of the cornea which is associated with thinning. So this part of the cornea is protruded and it is thinned out. And because of this protrusion, what do you see? You see an irregular astigmatism. So it's an irregular myopic astigmatism. And because of this irregular myopic astigmatism, there is the early sign that you get on retinoscopy is the scissoring reflex. So see, this is correct. Irregular myopic astigmatism, scissoring reflex on retinoscopy. And in advanced keratoconus, you get Munson sign. Munson sign means when you ask the patient to look down, the protruded cornea indents or presses your lower lid. So all these are correct. So which of them is wrong? What is wrong is this, that is Harb striae. Harb striae, what are Harb striae? Harb striae, they are stretch lines on the Descemet's membrane of the cornea, which are seen in what? They are seen in ophthalmos. They are seen in ophthalmos, that is congenital glaucoma. So these Harb striae, they are striae which are seen on the Descemet's membrane. And the speciality of the Harb striae, they are horizontal in direction, and we remember them as H for H. They are horizontal in direction. Now in keratoconus also striae are seen due to the stretching of the cornea. But what is the name of those striae? The name of the striae is Vogue striae. Now, Vogue striae, they are also striae on the Descemet's membrane, similar to the Harb striae. But what is the difference? The difference is that your Vogue striae, what is the direction? What is the direction of the Vogue striae? The Vogue striae, they are vertical in direction. So, Harb striae, we remember it as H for H, they are horizontal in direction. Whereas Vogue striae, we remember them for V, that is vertical in direction. So see, the answer to this question is Harb striae. Harb striae are not seen in keratoconus. They are seen in congenital glaucoma or ophthalmos. And what is the name of the striae seen in keratoconus? They are the Vogue striae, which are also striae on the Descemet's membrane, and they are vertical. Right? Let's go to the next question. Now, a farmer presents with pain and discharge in the eye, and he has sustained an injury with a leaf few days back. And what do we see in this? So see, what is this that we see in this image? This is a hypopion. The hypopion. What is hypopion? Hypopion means what? Hypopion means pus. Where? In the anterior chamber. That's what you see in this picture. So this is the answer. It is hypopion or pus in the anterior. Pus in the anterior chamber or hypopion. Now hyphema, what is this? Hyphema, this is blood in the anterior chamber, seen usually after some kind of trauma. There may be other causes, but one of the common causes is aqueous flare. Aqueous flare is turbidity of the aqueous in the anterior chamber. Why? Because of the increase in protein content. And where do we get to see this? We get to see this in uveitis. So in uveitis, there is a turbidity of the aqueous humor because of increase in protein. And what is Arlt's line? Arlt's line is actually seen in trachoma. It is seen in trachoma where there is a line of scarring on the upper tarsal. So So on the line of scarring on the upper tarsal conjunctiva is your Arl's line. Aqueous flare is seen in uveitis. Hyphema is blood in the anterior chamber, usually seen after trauma. And what we see in this picture is pus in the anterior chamber, is hypopia. Like, this is a simple question. I think everybody would find this easy. What is the most common cause of moderate to severe visual impairment according to the National Blindness and Visual Impairment Survey? Now, see, moderate to severe visual impairment in India is most commonly because of cataract. So, the most common cause of blindness in India is cataract. The most common cause of low vision in India is refractive error. So, moderate to severe visual impairment is the result of untreated. Most common cause of blindness in our population. Right? Let's go to the next question. The most common ocular manifestation of COVID-19. So, most common ocular manifestation of COVID-19 is follicular conjunctivitis. Follicular conjunctivitis. So, many upper respiratory tract infections, actually viral infections, they present with conjunctivitis, and it is typically a type of follicular conjunctivitis. Now, see, papillary conjunctivitis, usually it is allergic in nature. So, vernal keratoconjunctivitis, that's a type of papillary conjunctivitis. If you have ill-fitting contact lenses and they irritate the cornea, you end up with giant papillary conjunctivitis. So, papillary conjunctivitis, usually it's a result of, it's an allergic conjunctivitis. Whereas these kind of viruses which cause infective conjunctivitis, like COVID-19, it causes follicular conjunctivitis. Right? Simple question. Shall we go to the next one? Again, another simple question. In which of the following is atropine contraindicated? Now, what is atropine actually? Atropine is a dilator cycloplegic, right? It dilates the pupil and it's a very, very strong cycloplegic. So, it relaxes the ciliary body. So, see, in corneal ulcer and anterior uveitis, atropine has to be given. Why? In both these cases, it helps to relieve the pain. In acute anterior uveitis, atropine is given for pain relief. In corneal ulcer also, it acts as a cycloplegic and it helps to decrease the pain. In malignant glaucoma, what is the other name for malignant glaucoma? Malignant glaucoma is also called as ciliary block glaucoma. So what happens in this is that there is a malrotation of the ciliary body, as a result of which there is a posterior misdirection of the aqueous. So the ciliary body goes into spasm and it is malrotated, as a result of which the aqueous humor starts going backwards. That is malignant glaucoma. So here also, this atropine is the drug of choice. Why? Because it relaxes the ciliary body and brings it back into position. So for acute anterior uveitis and corneal ulcer, our atropine is given as an adjuvant because it helps relaxes the ciliary body and decreases the pain. In malignant glaucoma, it is a drug of choice because it relaxes the ciliary body and brings it back into position and actually addresses the main pathology. So in these conditions, it is to be given. So where it must not be given is acute congestive glaucoma. Now, acute congestive glaucoma, this is actually the old name for acute angle closure glaucoma. Acute angle closure glaucoma. So, in angle closure glaucoma, what precipitates ACG? ACG is precipitated by mydriasis, that is by dilatation of the pupil. So, we must never give atropine. What is the drug to be given in case of acute angle closure glaucoma? It's exactly the opposite of atropine. What you need to give is pilocarpine. Why we give pilocarpine? Because we need to constrict the pupil. Because in acute angle closure glaucoma, until and unless you constrict the pupil, the attack will not break. So to break the attack, we are supposed to give pilocarpine. So pilocarpine is to be given in acute angle closure glaucoma, and atropine is absolutely contrary. Right? So this is also another simple question. Let's go to the next one. A patient has presented for routine eye evaluation and the visual acuity on the Snellen's chart is found to be 6/6. Now, what is the angle of resolution? Now, see, when a person's visual acuity is 6/6, then every letter on the 6/6 line, every letter, it subtends an angle of 5 minutes of arc at the center of the eye, and each part of the letter, it subtends 1 minute of. So when a person's visual acuity is 6/6, what does this mean? When you make the patient read the Snellen's chart from a distance of 6 meters, then every letter on the 6/6 line for this patient is subtending an angle of 5 minutes of arc at the center of the eye, and each part of that letter is actually subtending 1 minute of. Okay, so assuming the patient's visual acuity is 6/6, we make him sit at a distance of 6 meters, ask him to read the 6/6 line. If he's able to read the 6/6 line, that's when we say that the visual acuity is 6/6. Now, technically, this means that every letter in that line is subtending 5 minutes of arc at the center of the eye, and each part of that letter is subtending 1 minute. So, therefore, the answer to this is 5 minutes. Okay, let's go to the next question. Which of the following is not a feature of complicated cataract? Now, complicated cataracts are cataract due to other ocular disease. So, one of the most important causes of complicated cataract is what? It is chronic uveitis. So, chronic uveitis is one of the important causes. Of course, it can happen in other conditions, like for example, in high myopia, in retinitis pigmentosa, in angle closure glaucoma. So, number of ocular diseases, they give rise to complicated cataract. Uveitis is one of them. Okay, so see, occurs after uveitis is correct. And this cataract, it has a granular appearance which is called as breadcrumb appearance, and also it shows polychromatic luster. So all this is correct. Polychromatic luster occurs after uveitis, breadcrumb appearance, all this is right. So what's wrong is Krukenberg spindle. So what is exactly Krukenberg spindle? Krukenberg spindle, this is seen in pigment dispersion syndrome. It is seen in PDS or pigment dispersion syndrome. So in pigment dispersion syndrome, what happens here? There is a rubbing of the zonules against the posterior iris epithelium. So the zonules, they rub against the posterior iris epithelium, and the iris pigments are lost and they get deposited in different ocular structures. So when they get deposited on the corneal endothelium, so that is called as Krukenberg. So pigments on the corneal endothelium. The iris pigments on the corneal endothelium, that's called as Krukenberg spindle. And it's a part of pigment dispersion syndrome. And where else do these pigments get deposited? I think all of you know they can also get deposited in the trabecular meshwork, giving rise to pigmentary glaucoma. So pigmentary glaucoma and Krukenberg spindle both are part of this PDS, that is pigment dispersion syndrome, which is classically described where this pigment dispersion syndrome classically described is in young males who are myopes. So young myopic male patient, that's where you get to see. Okay, so it's not a feature of complication. Right? Let's go to the next question. Again, very simple image based question. Identify this step given in the image. So this is one of the important steps of cataract surgery. So what do you see? You see that the capsule has been picked up by this capsulorhexis forceps and a circular opening is being made on the anterior capsule. So this is called as capsulorhexis. This is called as capsulorhexis. So here the capsule has not been stained, but sometimes to improve the visibility of the capsule, you can stain the anterior capsule using a dye which is called as the trypan blue dye. Then it becomes better visible. So you inject the trypan blue dye, stain the anterior capsule, then you can create a circular opening using the capsulorhexis forceps. But if you don't want to use the dye, then you can also do it without the dye, as you can see in this case. You can see the transparent capsule being picked up by the capsulorhexis forceps and you're rotating it to create a circuit. So this is your capsule, right? Again, another very simple question. Let's go to the next question. Again, an image-based question. Identify this image. Now, what is this image? This is called as a Hess chart. This is called as a Hess chart, and it is used to aid in the diagnosis of paralytic squints, where one particular muscle is affected. Where you have a paralytic, for example, if you have a sixth nerve palsy, or for example, if you have SOP, that is fourth nerve palsy, then these may help and aid in the diagnosis of, and also see if the person is recovering. Then you do a serial Hess charting to see the course of the recovery. So this is used for identifying paralytic squints. Okay, so this is your Hess. Now I just want you to have a look at the other charts. So see, what is this chart? This is your Pelly-Robson chart. This is the Pelly-Robson chart. And Pelly-Robson chart, this is a chart for contrast sensitivity. This is your contrast sensitivity. So see, in this chart, you can see that the letters, they become progressively fainter as you go down. So the upper letters are much brighter and they are easy to identify. And as you go down, the letters are becoming much more difficult to identify because the contrast or the brightness becomes lesser. So this is your Pelly-Robson. And what is this one? This is your ETDRS chart. Now ETDRS chart, this is, what is the full form of ETDRS? It is Early Treatment Diabetic Retinopathy Study chart, because it was used in this chart, in this study. That's why the name still remains Early Treatment Diabetic Retinopathy Study chart. And this is essentially a visual acuity chart. So you all know about the Snellen's chart, which is the most commonly used visual acuity chart. This is another one. This is the ET. So just to have a look at the images, the one that's given to us in the question is your Hess chart. This that is used, as I said, to aid in the diagnosis of paralytic squints and also see how the muscle is recovering. So to check the progression or to check the recovery. Next is, this one is the Pelly-Robson chart, the first one, where the letters become fainter as you move down and it's a contrast sensitivity. And the other one, ETDRS chart, it's a visual acuity. Right? Next, this is also an easy question. Again, another image-based question. Identify this image. So what do we see here? You see that there is these iris pigments deposited on the anterior capsule of the lens. This is called as the Vosch's ring, and this is often seen after blunt trauma. So when you have a blunt trauma, like for example, if suppose a ball hits the eye, then the iris, it moves back and it touches the surface of the lens and it comes back. So these iris pigments are deposited on the anterior lens capsule. So these iris pigments deposited on the anterior lens capsule. Now this is seen your Vosch's ring, as you see in this picture. Right? Now where do you see Wise ring? Wise ring is actually, this is seen in PVD, that is posterior vitreous detachment. Posterior vitreous detachment, there you get to see Wise ring. Where do you get to see KF ring? So this is what the KF ring is. It is a ring which is close to the limbus, and this is seen in Wilson's disease. Wilson's disease, you all know, it is due to the deposition of copper. So deposition of copper in the Descemet's membrane, it gives rise to this kind of a concentric ring close to the limbus, and this is called as your KF ring. Right? And where do you get to see Fleischer's ring? Fleischer's ring is a pigmented ring at the base of the cone that is seen in keratoconus due to the deposition of iron. So Fleischer's ring, that is deposition of iron at the base of the cone. This is seen in keratoconus. Vosch's ring, deposition of iris pigments on the anterior lens capsule seen after blunt trauma. KF ring, this is due to the deposition of copper seen concentric to the limbus in Wilson. And Wise ring, this is seen because of just okay, another sort of one-liner which is also image-based, but a simple and good question. Let's go to the next. Again, a question that has been asked many times and likely to be asked again. Where is the lesion which can cause the defect, the given visual defect? So first of all, whenever we get this, I've told you many times that what we have to do, we have to mark out the right and the left. And the right and the left are according to our own right hand and left hand. So this is right and this is left. And we mark out the nasal and the temporal field. So the nasal is the inner side and the temporal is the outer side. So what do we see here? What is this? See, the temporal fields of both the eyes, they have been blackened out. So what is this defect? This defect is called as bitemporal hemianopia. So this defect is bitemporal hemianopia. And what is the other name for bitemporal hemianopia? It's also called as heteronymous hemianopia. And where do we get to see bitemporal hemianopia? What is the site of the lesion? The site of the lesion, obviously, the optic chiasma. So if you mark out the right and the left, the chances of getting this question wrong becomes very minimal. So you see, you mark out the right and the left, mark out the nasal and the temporal, and see now the temporal fields of both the eyes are blacked out, suggestive of bitemporal hemianopia, so site of lesion. right? Shall we go to the next one? Another similar question. Once again, see, we mark out the right and the left. This is the right and the left, and I mark out the nasal and the. So what do you see? You see that the nasal field of this eye and the temporal field of this eye are affected. So the nasal field of one eye and the temporal field of other eye are affected. So when you have this, now we are going to call this as a homonymous hemianopia. But see, this is not just a homonymous hemianopia. This is a very special kind of homonymous hemianopia where the central portion is actually clear. So this is a homonymous hemianopia with central or macular sparing. With central or macular sparing. So where do we get to see homonymous hemianopia with macular sparing? We all know that this is seen in lesion of the occipital. Now comes the slightly difficult part. Now see here, am I supposed to call it a right homonymous hemianopia or a left homonymous hemianopia? Now if you look at this picture, see the nasal field of the left eye and the temporal field of the right eye are affected, correct? The nasal field of the left eye and the temporal field of the right eye are affected, which means that the blackening is on my right hand side. So this is to be called as a right homonymous. So the nasal field of the left eye and the temporal field of the right eye are affected, which means that the blackening is on my right hand side. So this is a right homonymous hemianopia. And if it's a right homonymous hemianopia, site of lesion or left occipital, or we should say the left occipital lobe, the left occipital answer. What is the answer? The answer is the left occipital. So the picture given to us is a right homonymous hemianopia with central or macular sparing, site of lesion, left occipital. Okay, so this is a commonly asked question, and commonly what students get wrong is actually between the right and the left they get confused. So I hope you will not get confused. Right? Shall we go to the next question? A patient has presented with this picture. So this is like a 9-gaze photograph. And whenever we have a 9-gaze photograph, what we have to do is we have to look at this central picture, because that helps us to identify this is your primary position. And this central picture night actually helps us to understand which is your affected eye. Because if you look at the other pictures, there is a possibility you might get confused. So always look at this central picture, which is the primary position. So now if you look at the primary position, what do you see? What are the features you can see? So you can see that there is a severe ptosis, right? So there is a severe ptosis, and if you look carefully, the eyeball is down and out. Look at the iris in this eye, that will give you a feature, and compare it with the other eye. You see that the eye is down and it is out. So severe ptosis and eye is down and out. What does this mean? What nerve palsy? We all know that this is third nerve palsy. So severe ptosis because the LPS is affected and the eyeball is deviated down. Now, just to confirm, look at the movements. See here, you can see that this left eye, here the abduction is present, right? It is abducting. So, abduction is present. So, the left eye, abduction is present. And if you look at this, the pictures below, you will see that the left eye, depression is present. So, it is able to abduct and it is able to depress. But see, if you look at the left eye is not, look at the upward pictures, left eye, the elevation is affected, and for the left eye, the adduction is also affected. Left eye, the adduction is also affected. So the left eye, if you look at the left eye, we've understood that the left eye is affected, is the affected eye. What are the features in the primary position? There is severe ptosis, the eye is down and out. What are the movements remaining? You can see that the left eye is able to abduct and the left eye is fairly able to depress. It's not able to depress completely maybe, but it is able to depress to a certain extent. So the depression is okay, the abduction is good. The abduction is good, the depression is fairly good. Right? The depression is fairly good. But if you look at the elevation and if you look at the adduction, they are affected. So once again from this, we understand that this third grade. Why? Because the abduction is affected because the LR is spared. The LR, it is spared. The LR is spared. So that's why it is the abduction is spared. And the depression is possible because the SO is spared. The SO is spared. So that's why the depression is also partly possible. Right? So we have two depressors, inferior rectus and superior oblique. So the depression is partly okay because the SO is spared. The abduction is completely okay because the LR is spared. The other movements are affected because the other muscles are affected. This is a picture of third grade. But these movements only help you to confirm the diagnosis. To be able to diagnose, now what you have to do is you have to look at the primary position. That will give you the clue. So see that severe ptosis and the eyeball down and out, that immediately tells you the diagnosis is third. Right? So I hope this is clear to you now. Let's go to the next question. Which of the following is not a component of safe strategy for trachoma? Very, very, very simple. So S stands for surgery, A for antibiotics, F for facial hygiene, and what is E? E is not evaluation. E is environmental modification. So improvement of hygiene, improvement of overcrowding, this is what needs. So surgery, antibiotics, facial hygiene, and environmental modification. That is your safe. The evaluation is not the E. So E is not evaluation, it is environmental. Right? Let's go to the next. Again, a question that has been asked n number of times but likely to be asked again. A patient presents with pain and redness in the eye following trauma with vegetative matter. Keyword. So there is a corneal ulcer. So the ulcer is dry and the margins are feathery. So see, these are the keywords. So whenever they say that there is trauma, there is a corneal ulcer, pain, redness, photophobia following trauma with vegetative matter. The surface of the ulcer is dry, the margins are feathery, or if they mention multiple lesions, that is satellite lesions. And if they mention that there is a hypopion and the hypopion is very thick, which means that it is a fixed hypopion, it's an immobile hypopion. And if these words are also given in the question, then the diagnosis becomes even more easy. Corneal ulcer. But even without this, we can still say it's fungal corneal ulcer because they have given us three very, very important pointers. That is trauma with vegetative matter. The surface of the ulcer is dry. Sometimes the word leathery is used. Dry or leathery surface. Sometimes the question may also mention there are multiple lesions or satellite lesions. Margins are typically described as feathery, ill-defined, or fuzzy. And hypopion, if present, sometimes the question mentions that it's a very thick hypopion, it's an immobile hypopion. So all these point to the diagnosis of fungal corneal. Like this is like a question that we must know like the back of our hand. This is very, very, very important. Commonly asked in all exams, whether it is NEET PG, whether it's FMG, whether it is INICET, something that's important for all exams. Right? Okay. Let's go to the next question then. Which is the most common lacrimal gland tumor? Again, a one-liner. The answer is pleomorphic adenoid. The most common lacrimal gland tumor is a pleomorphic adenoid. Next question. A patient presents to the emergency department with aqueous flare and KPs. So aqueous flare and KPs gives us what diagnosis? Where do we get keratic precipitates and aqueous flares? We get it in uveitis, right? So uveitis. And his intraocular pressure, IOP, is elevated. So there is uveitis and there is also high IOP. So this is what the diagnosis is what? It is uveitic glaucoma, or we can say inflammatory glaucoma. Uveitic glaucoma or inflammatory glaucoma. So often in uveitis, what happens is that these inflammatory cells, they clog the pores of the trabecular meshwork and they cause aqueous outflow obstruction. And because there is aqueous outflow obstruction, then the pressure often rises. So this is called as uveitic or inflammatory. Now the question is that which anti-glaucoma drug should be avoided in this patient? So in uveitic glaucoma, typically we must avoid PG analogs. Why? Because PG analogs, they have two important problems. One, they increase the uveitis, and also they cause cystoid macular edema. So they increase the intraocular inflammation. So they are known to cause intraocular inflammation. So if the eye is already inflamed, the PG analogs may further increase the inflammation. And they also increase the risk of cystoid macular edema, because we know that uveitis, there is anyway a risk of cystoid macular edema, and PG analogs, they also increase the risk of CM. So together, it might not be a good idea to give PG. Another class of drugs which is also avoided is the alpha receptor agonist, which means brimonidine. Brimonidine is also not to be given. It has the same two problems. This brimonidine also increases intraocular inflammation, and it also increases the risk of cystoid macular edema. So PG analogs are not to be given, and brimonidine is not to be given in case of uveitic, and the others are okay. Okay, let's go to the next question. What is the classical route of spread of retinoblastoma, or what is the most common route? Now, the most common route is actually, the answer to this question is direct spread via the optic nerve. Direct spread via the optic. Now, see, unfortunately, the recall question says that both direct and optic nerve are given. So if both are given, we should probably choose optic nerve as the answer, because direct spread can also be through the sclera. There are two possibilities of direct spread. One, it can spread to the orbit via the sclera, or it can spread posteriorly via the optic nerve to the brain. And the direct spread via the optic nerve to the brain is more common. That's the most common route of spread. So that's why out of these, we should probably choose the optic direct spread via the optic nerve to the brain. Right? Let's go to the next one. A child comes with a left-sided head tilt. Now, when the doctor corrects the head tilt, he notices a right hypertropia. So what are the features? The features is right hypertropia. So the right eye is raised up. And this hypertropia, it increases on levoversion. Levoversion means opposite side gaze, that is opposite gaze. So there is a right hypertropia which increases on opposite gaze, and it also increases on the same sided head tilt, that is on right head. And because it is increasing on the right sided head tilt, and that is precisely why the child has tilted his head to the left side. So the child has tilted the head to the opposite. Okay, so there is a right hypertropia. There is a right hypertropia which is worsening on opposite gaze and same sided head tilt. And that is why the child has an opposite side. So this is typically SO palsy, that is superior oblique. So please remember that out of all this, what you will get in the exam is SOP only usually, because that is what is commonly seen in practice. So in SOP, there is a hypertropia which worsens on opposite gaze and same sided. So it worsens on opposite gaze and same sided head. Okay, and that is why the patient has an opposite side head. So see, in this question, what is given? There's a right hypertropia which is worsening on levoversion, means opposite side gaze, and on right sided tilt, that is same sided tilt. And precisely that's why the child or the patient opposite left side. So the answer is right SO, right sided superior oblique. Okay, let's go to the next question. See, there is a corneal abrasion. Now, corneal abrasion can happen with dust, dirt, sand, metal particles, contact lenses, etc. Now, what do we mean by an abrasion? Abrasion actually means that there is a breach of the epithelium. So, which of these is incorrect? It is lined by stratified squamous epithelium. Correct. So, this is correct. It is stratified squamous, non-keratinized epithelium. So, this is right. Stratified squamous, non-keratinized. The apical cells, they have microvilli. This is also correct. Mitotic activity is seen at the limbus. We know that the limbus has the stem cells. So obviously there will be a lot of mitotic activity at the limbus. So lined by stratified squamous non-keratinized epithelium, apical cells are microvilli, mitotic activity. All this is right. So what's wrong is this. See, Bowman's membrane regenerates. The Bowman's membrane has no regenerative potential. The Bowman's membrane does not have any regenerative. So this is what is wrong about it. So the Bowman's membrane is like just beneath the corneal epithelium, and the epithelium can regenerate. So if there is an injury of the epithelium, it will regenerate and there will be no formation of scar. But if there is a breach of the Bowman's membrane, because the Bowman's membrane does not have regenerative potential, scar. So this is what is wrong, right? Now let me go to the next question. A 55-year-old man is undergoing a cataract surgery workup. Now previously he has undergone LASIK surgery for the correction of myopia. Now which is the best method for IOL power calculation? So basically the question is trying to ask which are the formula to be used for IOL power calculation in patients who are post some form of corneal refractive surgery. So this is a patient who has previously undergone a corneal refractive surgery and now he has come for cataract surgery. So for a patient who is post corneal refractive surgery, which is the IOL power calculation formula to be used? The answer is 𝐒𝐿. So these are advanced formulae, and out of the options that are given to us, this is the formula that is to be used in patients who are post some form of corneal, right? So these are a few important PYQs that I wanted to discuss with you. So the idea is to tell you about, just let you know about what are the important topics that you should revise before the exam. So see, the questions may not come the same, but usually in most exams the topics remain the same. So this, I hope it gives you an idea as to which are the topics in ophthalmology that you have to, because even if as I said, the questions may not be the same, but kind of something related to these topics only are asked. Okay, so I hope this short session has helped you with the previous year's questions. I wish you all the very, very, very best for the exams, and I'm sure that you'll study well, keep your calm during the exam, and the calmer you are, the better your results are going to be. Actually, what happens is that we study a lot, but in the exam, the stress levels as they start, it becomes very, very difficult to recall and apply all that you did. So on the night before the exam, do sleep well, stay calm during the exam, and try to recall and apply everything that you have. So all the very, very, very best. Thank you very much.